Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast. I'm your host, Dan Carter. I've got Dr. Zoe Latimer here with me here in the studios at Countryside Equine Hospital.
Good morning.
Yeah, we're a little studio, treatment room 1, as we like to call it, the rest of the week. So, Dr. Zoe, we got a great topic this week. Jenna P. actually sent this one in. Thanks for sending that in. Remember, you can always send in questions. We're going to do our best to get everything you want answered. So, again, thanks for Jenna P. for sending this question in. Joints.
Yep. Super important.
All about joints today. We're going to do a deep dive into joints, their function, their physiology, why we inject, why we might not inject, things to consider. Unfortunately, we will not have time to get into all the different products out there. Y'all going to have to tune in again to catch that, because that's a rabbit hole, isn't it? That is.
Well, that could be multiple episodes in itself, just between the types of products, how often we can inject, what we can inject, the mixture of injections, et cetera. So that's going to be a whole nother thing. But I think we're going to start with the basics today. We'll start with the step 1 of just joint anatomy first off.
Right.
So,
and interesting enough, I think this is a great topic because the number one cause of poor performance in the equine athlete across all disciplines, everywhere, the number one cause is lameness.
Yep.
Number one cause of lameness, the joint.
Yes.
So it's a really great topic. So let's talk about the anatomy of a joint. What is a joint? What's going on in there? How does it work? Let's do it. Let's just go ahead and dive off in it. So what we got there, Zoe?
Well, so basically joints are where you have a pocket of fluid where two bones come together at a flexure. And there's a capsule that holds the fluid there at the junction between the two bones. And the fluid we call synovial fluid. I'm sure you guys have probably heard that term. If you ever been around, you've seen a lameness exam on your horse, or if you've seen joint injections, and it's when they stick the needle in to do the actual joint injection, it's the should be somewhat clear yellowish fluid that comes out of the needle before we actually inject the medication into the joint. So that's your synovial fluid. But that joint capsule holds it all together, holds it in a nice little package there.
It's like a little balloon in there. That joint capsule's got a lining of synovium.
Yep.
All these words kind of blending together now. So you've got that lining of the joint capsule that's filled with synovium. These little hair-like cells in the joint. These are what produce the joint fluid. And you hear us talk a lot about joint fluid or synovial fluid. We use those two things interchangeable, but joint fluid is truly the glue that holds the world together.
Yes. Yeah.
In my opinion. So interesting enough, when we're looking also at that anatomy of the joint, everybody thinks about bones and they think about articular cartilage, right?
Well, so you have the actual bone itself, like the long bones come down, and at the end you have cartilage that is kind of like the cushions, right? At the surface of the joints. And then where the cartilage is attached, you have what we call subchondral bone. But the cartilage is kind of helps to cushion at the surface of the joints.
To me, it's the eighth wonder of the world, right? We're talking about 5 millimeters, average cartilage depth, 5 millimeters.
Yeah, not much. Yeah.
5 millimeters. And it's called a non-Newtonian fluid. You realize that, like joint fluid? It's considered non-Newtonian because, interesting enough, it's like, have you ever seen those gels on YouTube that people make up and they can put their hand on it and they push on it and it sinks down in there? And if they go up and like punch it, it like turns almost to a solid. You ever seen that?
Yeah,
right.
I've seen that. Yeah.
That's a non-Newtonian fluid because, and interesting enough, that's how joint fluid interacts with cartilage. It's non-Newtonian. So, I'm over nerding here. I just realized, but when you hit this joint
That's
fluid,
going to happen quite a bit today. Just wait till we get to the MMPs. He's going to lose his mind.
I know rednecks like to read. But yeah, when you actually hit that joint fluid, it actually turns in like this almost viscoelastic solid. And so you've got this 5 millimeters of joint cartilage on each side of this joint. So you got a total of 1 millimeter, and we're going to say that's going to cushion the joint. Eighth wonder of the world. I don't know. Non-Newtonian. There's your word of the day. Go look that up.
That's right.
You know, and I think it's also important to talk about. We're always talking about cartilage. But you know, where does cartilage get its nourishment from? And it's all about joint fluid. Really and truly, it's all about synovial fluid, because synovial fluid's what actually provides the nutrients for your articular cartilage to live. It doesn't have a blood supply. It doesn't have nerve endings. The nerve endings are in the lining of the joint, the synovium, and the joint capsule. They're where the joint capsule inserts in the bone and the subchondral bone, but cartilage itself doesn't have a nerve ending. But it also doesn't have a vascular supply.
Correct, yeah.
So that joint fluid is the only nourishment it has. So to me, if we're going to delve off into when to inject, why to inject, I think that's our most important thing, is we got to understand this joint fluid. Save the joint fluid, save the world, right? It's like save the cheerleader, save the world. So we've got to go save this joint fluid.
I haven't heard that one, but yes.
Yeah, you should know that, Zoe. Save the cheerleader, save the world. Save the joint fluid, save the world. So
healthy joint fluid. So, you know, we do a lot of joint injections, you and I, but, you know, people listening to this podcast may not know what healthy joint fluid should look like. So healthy joint fluid you should be able to, basically what they say is you should be able to read a newspaper through it. It shouldn't be cloudy. It should be relatively clear to slightly yellow in color, and it should be pretty jelly. It should be like viscous is the word, kind of not quite as sticky as something like honey, but it shouldn't be runny. It should not be like water. And if it's very thin, like water, that is an unhealthy joint fluid. Or if it's red tinged in color, orangey, that's really unhealthy joint fluid, meaning that your horse's joint is pretty deteriorated. So.
Yeah, I always think about the three bears, right? And old Goldilocks. You don't want it too thick.
Too thick is not like honey, but not like water. You want it somewhere in between, nice and jelly, and like you should be able to put it between your fingers and kind of have a little bit of stretch between it.
We call it a string, right? You got to have a little bit of string.
Yeah. So.
But yeah, I always think about that. Not too thick, not too thin, just right. Again, non-Newtonian.
Nice and clear. You want to be able to read through it.
So let's talk about how joint fluid is made, which is, you know, basically we're going to get into like the physiology of the joint, right? How joint fluid's made, what it consists of. So two things, right? PGAGs, old polysulfated glycosaminoglycans. Last time I'm going to say that. So we're going to just know when we say PGAG, we're talking about polysulfated glycosaminoglycans, chondroitin sulfates, and glucosamines, right? And then hyaluronic acid. OHA. That is also the glue that holds the world together. Those are main components, right?
That's right.
What about the bad stuff? This joint's mad. It starts making a lot of bad stuff, though, right?
Yeah. Prostaglandins. Yep. Your MMPs.
Ooh. And my all-time favorite is interleukin-1.
Beta.
I love interleukin-1.
Yeah.
TNF-alpha's in there. Good stuff. These are things we don't want in joint fluid, right?
Correct.
We don't want
those
them
are pro-inflammatory cytokines. We don't want those guys in there. Those activate your inflammatory cascade. So the inflammatory cascade is this negative feedback loop that once you get that going, that leads to the development of arthritis.
Yep.
So the entire principle behind why we even inject joints in the first place is we are trying to insert ourselves into that feedback loop to cut the cycle and completely cut off the inflammatory cycle. So if we stop the cycle, we can slow down the progression of arthritis. So.
Yeah, because it's, if I was to describe what happens to make a joint inflamed is we have some type of an insult, right? Whether that be an instability, one bad step, chronic wear.
Yep.
some kind of traumatic event to the
Some
joint.
sort of inciting inflammatory event, whether that is basically for us, it would be like a twisted ankle, or we went for a really hard run, or.
Trampoline park.
Yeah.
I was at the trampoline park once with my kids, and I thought, there's this guy jumped up there and did a backflip off the wall, and I was like, and my kids are like, "Dad, can you do that?" I was like, "Yeah." So of course I did the whole bounce backflip, landed, the old knee twisted, and about a day or two later, I was in the doctor's office and I was getting me a little joint injection in the old knee.
Yep.
So definitely got that inciting cause.
So therefore, you had a inflammatory event,
I did.
aka you had the start of your pro-inflammatory cascade, right?
You're gonna start producing that interleukin-1.
You had an influx of your MMPs, your IL-1 betas, your prostaglandins, your TNF alphas.
And the crazy part, that we call that physiologic debris, right?
Right.
Physiologic debris. There's physical debris, and that's like a chip in a joint.
Mm-hmm.
And then this whole group of things, we'll call them physiologic debris, meaning they're not physical, they're metaphysical.
There are things that are inside the joint that should not be there.
Correct.
And your body recognizes them as a foreign substance.
And these are, some of these, like the MMPs, matrix metalloproteinase, anytime you hear ACE behind the word, that's an enzyme. Enzymes can be good, enzymes can be bad. So there's no ACE means enzyme. So proteinase.
ASE, not ACE, not
Correct.
the ACE that we give them for sedation.
Good call on that.
He's saying ASE.
ASE, yes. Alpha Sierra Echo, ASE, so ACE. So that protease is actually going to start degrading joint cartilage. Mm-hmm. All right, and when joint cartilage starts to degrade, it produces more IL-1, more MMPs, more PGEs, more of this physiologic debris. We get
Right.
more physiologic debris.
Well, all these inflammatory cytokines that are there, they're recruiting all of their buddies. They're saying, hey, we're having a party. Y'all come on down.
It's like a giant frat party in the joint.
Right.
Next thing you know, the TV's torn up. There's a hole in the wall.
Yep.
And you're like, what happened to the front door? I mean, we've all been there.
Yeah. So then by the next thing you know, you got to invite the whole fire department over.
Exactly.
Instead of, we could have just dumped a cup of water
Could have.
and had the whole thing under control, but instead we got to bring the whole fire department.
So, that's the cycle we're talking about.
Yeah.
And we get into that cycle, and that's what's going to actually cause degradation in your joint over the long term.
Correct.
Chronic inflammatory state causing degradation of the joint.
Right.
And if you really think about it, the longer we can preserve that joint, the longer we can preserve this horse.
Right.
One of the things I think about is I remember, oh Lord, until my age again, go back 25 years ago when I started shoeing, there was not a 20-year-old athlete out there. I mean, you used to ride dressage. Mm-hmm. These 20-year-old athletes were few and far between. We routinely have them going into their late 20s now, or not late 20s, but early 20s at pretty high levels. Mm-hmm. And I think that's because we do a better job at maintaining those joints. Because once you lose articulated cartilage, it ain't coming back. Mm-hmm. Like once we're done, we're done. Mm-hmm. And so the sooner we break this cycle, the sooner we get this fire under control, the longer we can preserve the health and integrity of this joint.
Right. Yeah, no. Early intervention is definitely key. And I'm talking about early intervention into that inflammatory cycle.
Yes.
So early intervention is key to preventing that later progression of arthritis down the road. So the sooner we get involved, the sooner we start just pouring a cup of water on the small kitchen fire, the later we don't have to bring in the entire fire department to put the whole house fire out.
That's 100% right. And that's one of the things I hear a lot is my horse is too young, or is it too early to have an injection in the joint? And I always say no.
Right.
If the joint needs it, the joint needs it.
Yeah.
And
They're like, but he's only 4. I'm like, well.
Yeah, he's 4. He's growing. He got some laxity. He got an inflamed joint. This joint capsule's upset. Mm-hmm. It's producing these inflammatory mediators. We got to get rid of them. Mm-hmm. And a lot of times we can do that one time, right? Mm-hmm. And we may never touch that joint again for years. Mm-hmm. But for whatever reason, that one moment in time, that's what we need.
Yeah.
And so I think when we're talking about that, like where does the pain, we talked about where the pain comes from, but truly that unsung hero of the joint is those synovial cells, right? Those synoviocytes. Mm-hmm. Those are those little hair-like cells that we talked about earlier on that on that joint capsule that produces synovial fluid that are producing those PGAGs and HA. And interesting enough, like when you watch, like I've ultrasounded a lot of joints, especially stifles. I've ultrasounded a lot of them. You look at them pre-injection and you've got really thick synovium in there. You got a thick joint capsule. I call it snow globe, and we got fibrin sitting in this joint. We got a lame horse. And what's really cool is we'll medicate that joint, and some of these I get to follow up 30, 45, 60 days later. We'll put that ultrasound back on, and it's amazing to see just how much quieter that joint's got. The synovium have quieted down, that joint capsule's quieted down. The horse is sound. It's amazing the difference that we see with that medicated, when we medicate that joint.
Yeah.
So you can physically see what these products are doing. So, so one of the questions I get asked a lot is about chronic use of steroids in the joint. And people, they don't like to inject the joint that often. And one of the reasons is in humans they have an issue called steroid-induced chondromalacia. They're going to get softening of the joint cartilage over time, and the steroids actually degrade joint cartilage. And so I like to call it Steinbeckian biology, where it's of mice and men. Everything that we look at, it's either in mouse models or we try to extrapolate from humans. But as we have learned, being equine practitioners for a while, horses are like neither, right? And good for us, like the steroid-induced chondromalacia just doesn't happen in horses. We don't see that weakening of the joint cartilage. We don't see that thinning of it secondary to corticosteroid use. And then, like I said, we'll get into some other episodes. We're talking about we've got a lot of other options, right?
Right.
But if we're just looking at straight corticosteroid use, we don't see that softening of the joint cartilage. We don't see that steroid-induced chondromalacia. And so we can actually break that cycle, get those synovium back normal, and actually get a repair of this tissue. So that's one of the things I'm thankful of in horses, because they're pretty rough on these joints sometimes.
Yes.
And we do have that to help us. So Zoe, when you're looking at a horse, what are things you look for that say, hey, I may need to inject this horse? What are the things you're doing? Like, talk me through. You pull up, you've done a workup. What are the things you're seeing that says, hey, we may need to inject?
Well, I mean, typically, you get a call from an owner and they're saying, my horse he's not dead lame, but it's just not performing like he usually does. And maybe he does normally get routine, what they call like maintenance injections, and he's maybe coming due for those, or maybe he's never gotten maintenance injections before, but he's not showing like he was, or he's really starting to, when I put my leg on, he doesn't want to move off my leg like he used to, or bend like he used to. And the owner says, I've kind of gone through the list of my checkoff list like I normally would, like my saddle fits, my bridle fits, it's not X, Y, and Z. I just want you to look at him, make sure he's not hurting anywhere. And I watch him jog out, and he's jogging out pretty sound, but we start doing some flexions of his joints, and he's, a little ouchy here and there. And there's usually when they need, quote unquote, when they need joint injections, they're pretty similar from left to right. Like, say, for example, if your horse needs hock injections, the flexion of the left hock is pretty similar and a positive reaction to the right hock, I would say. Sometimes the left is a little bit more sore than the right, but rarely do you, or at least me, rarely do I see the left is extremely painful and the right is completely fine.
I'd agree with
I don't really see that much. I usually see a little bit of positivity on both, and I'm like, ooh, yeah. When I do see one is really painful and the other one is completely fine, is more of an injury. That, to me, that's more of a signal that there's more of an injury going on rather than a straight up just injection going on.
Let's talk about, for those that may not have seen a workup, you said when they're flexing.
Oh, yeah.
Let's talk about what that flexion test looks like.
Sure. So backing up, going to a lameness exam, we just watch the horse jog in a straight line back and forth first. And when I'm doing flexions, we take turns going from one limb to the next. We do all 4 limbs, and we're flexing each flexing each joint individually. And flexing, I'm actually bending the joint at its maximum as much as that horse can, not trying not to completely crank the joint all the way down to create pain, but flexing it in such a way that is a little bit, I would consider unnatural, sort of, because a horse is not going to stand in the pasture with its knee completely bent for 30 or 45 seconds, so that is a little bit unnatural. But then I release the leg back down, trot them off, and if they're hesitating on the limb or kind of head bobbing or propping their shoulder when they're trotting off, then I consider that a positive flexion, meaning that there was some sort of pain associated with that flexion of that joint.
Changing gait. That's what I look at. Like we set a baseline.
It creates an asymmetry in the gait from what I witnessed as the baseline. So that's why we always just jog them out first before we do anything. So because I'm establishing a baseline. So I watch them trot first without touching them. I just want to see what the horse is giving me today as their baseline. And then I start manipulating the joints. And if I'm witnessing a change in gait, like Dan said, or an asymmetry of any sort, then I consider that a positive change.
And a lot of times they're little subtleties, right? It may not be the full-on head nod. Sometimes I'll see, as I say,
it's nice when they give you the full-on head nod.
Yeah, that's great.
You're like, check.
But sometimes we're just watching, and you'll see where they'll hold their heads slightly.
Sometimes all you hear is
center.
a sound change.
That's huge. Sound change is important.
Yeah.
But you'll see a slight excursion in the leg, like on the hind legs. A lot of times you'll see them deviate to what we call axially, or deviate to the inside where they weren't doing that before. Forelimbs, oftentimes I'll just see a subtle change in neck position. They were straight.
Yeah.
And now, let's say I flex the left front, I see a little deviation of the head to the right.
Yeah.
They're trying to get off of that. And for everybody that's over 40, you'll understand this analogy. If you're under 40, you've got no clue, but welcome, or just wait, it'll happen. If you squat down and you're squatted down for a few minutes and you stand back up,
and then you're supposed to jog off.
And you're supposed to jog off. All right, that's the flexion test, okay?
Yes.
That's what we're doing. For you people under 40, just wait. You too will understand what a flexion test is like.
I do that now. Do you have to be over 40?
I started young myself. I was just trying to just help people out. So doing the flexion test, and the same time I'm doing the flexion test, I'm also feeling what we call a fusion, right?
Yep. So part of a lameness exam, that's what we call, like when I'm evaluating horse to see if it needs joint injections, we call that a lameness exam or a performance evaluation. Those terms can be interchangeable, kind of depending on what region of the United States you're in. We're usually palpating the horse pretty much from head to toe, feeling all the joints, feeling for effusion or fluid in the joint. That's puffiness in the joint, reactivity from the horse, like watching their facial expressions change as you're feeling the joint, moving the joint. If the horse is kind of giving you any sort of bodily reaction, swishing their tail, they don't like it, or even if their expression doesn't change, but you can feel the difference in a really fluidy joint versus one that's really clean and flat in a really young horse.
Well, that effusion, that excess fluid's in the joint, it goes all the way back to that cycle we were talking about, right?
When we talked about in the very beginning, so all of those inflammatory cytokines that we had talked about in the beginning, when you have an angry joint, those inflammatory cytokines lead to a puffy joint. They recruit in more fluid inside the joint. So
I think the way to think about that is the body doesn't change, right? It always has the same type of reaction. If you've ever had a bruise, what happens? It swells, right? You have trauma to your arm or your leg, you get swelling.
Yeah.
Trauma to the joint, guess what? It swells too.
Yes.
It's all the same enzymes, all the same process.
That's right.
It's not magical because it's a joint. I mean, I think joints are magical, but not everybody probably thinks of them that way. But yeah, we're feeling that effusion. We're checking those positive flexions. I think that's a big thing. One of the things, like when you're talking about what you often get a call for, one of the things I hear a lot is taking a lot longer to warm up. Usually I can get on like 15 minutes of warming up. Now this is drifting out 20, 30 minutes before I'm warmed up. Can't come out the gate as fast as I could. And then also there'll be a subtle decrease in performance. A lot of the horses I work on, it's that subtle decrease in performance. They're not jumping as clean as they were. Their changes aren't as smooth as they were. They're having a lot of my dressage horses. The first place we see it, the pee off and the passage.
I was going to say probably, yeah. Or the changes. Yeah.
And the changes. Western performance horses, a lot of my reiners, they're not stopping like they used to. They're not sliding as well. Their spins are starting to not be as clean as they were. Things aren't as effortless. Barrel horses, it's always about the clock, right? You know, they're 2/10 off, 5/10 off. And we don't think about that being much, but, you know, that's the difference between winning and not. And so a lot of times it's these little subtle things that we're often hearing that lead us to what's going on. And,
Right.
you know, the other thing I look at is kind of a good generalized rule of thumb. This isn't always the case, but a real general rule is these horses that may start off, let's say like a 1 out of 5. But then as you're going through, you've jogged them a few times, you may have lunged them, and the lameness is gone. They work out of it. That's starting to lead me towards maybe we have something with the joint, because oftentimes that joint, they'll warm out of these lamenesses. They warm up better. Again, if you're over 40, you'll understand that when you first get out of bed, you're a little slow, you're a little sluggish. But once you get to moving, life's pretty good. Me, I get out of the truck before I had seat heaters in my truck. Greatest thing in the world, by the way, is a seat heater in a truck. If you're over 40, you should have those. You know, I get out of the truck and I'm not moving as well. Not about 10 minutes in this appointment, you know, I'm back like ready to roll, right? I'm back in my prime. It just takes a while to get there.
Yeah.
So, you know, I think all those things are things both of us look at. We're thinking maybe we've got this joint. And I think the other thing is you've got to make sure, and I think this is the most important thing, you don't want to just say, hey, I get his hocks done every 6 months, so that's just what it's due for. We need to evaluate, because what if it's not the joint? And the other thing is there's more things going on in that joint than just a synovitis or just an arthritis condition. We need to make sure we don't have collateral ligament involvement. We need to make sure we don't have other factors that are causing him to flex positive or look like he may need a joint injection. So I think that's critical. The workup, the performance evaluation, or layman's evaluation. I use performance evaluation, my terminology.
Yeah. I think it just depends on who trained you,
Right.
where you grew up.
I agree. I think that is probably, and you've heard us say this on the podcast a lot, right? The exam's everything. Clinical exam,
Yes.
everything.
Yeah.
We've got to sort through this. And there's times we may need to do some diagnostics, right?
Oh, absolutely. Yeah. That's absolutely so important. You can't, and I think one of the most important things that you can, as a horse owner, number one, and as a veterinarian, don't make assumptions about any of it. Don't
Right.
just because your horse is off, don't just assume, oh, he's due for his joint injections. You know, don't just make assumptions. Take the time to actually do the performance evaluation and do the flexions. Don't just bring him in, be like, all right, just stick them, let's go. Because that's how you get down into a potentially dangerous situation. So
One of the things I love to do when I'm looking and thinking about a joint, especially when I don't know the horse as well, a lot of the athletes I'm working on, I've been taking care of them for years, and you pick up on these patterns, right? You got these ideas of what's going on, you sort of know. But sometimes when they come in and they're lame or they're not performing well, I'll use a joint block. So we'll actually go in and we'll put carbocaine, which is similar to a lidocaine.
I love a joint block.
Yeah, exactly.
I do them all the time.
You go in, you block this joint, right?
Oh,
and if this
I
thing
love doing
blocks
them.
out 10 minutes,
I'm like, you know what? Why not?
yeah, we're here.
Yeah.
We know.
I can still inject the joint afterwards.
Absolutely. Yeah, that was one thing when I first got to school. They're like, you don't want to block and inject the same day. And
Oh, I do it all the time.
I got out in the real world, and I remember I said that, and they kind of laughed at me. And I've been doing it 15 years, haven't really had an issue.
Yeah, do it all the time.
I asked a very well-known lameness clinician once, like, how long do you wait after you've blocked the joint until you inject it? He goes, I
10
don't
minutes.
know. How long does it take to scrub the joint the second time? And I was like, okay, if this guy can do it, and this guy's written a lot of books, I was like, if he does it, yeah, I can do it.
If you're ever in question about it, just block it.
Block the joint.
I can't tell you how many that I have done, and it has been it helps you sleep at night for sure.
It does. Like, I love it when I block that joint, and like 10 minutes after the block, that horse is 100% sound.
Yep.
doing great. It's like, all right, bam,
Yep.
let me grab some meds. Let's block this joint, or let's inject this joint.
Yeah. Same.
So I'm a big proponent of that. So let's get in, because, and I can tell you, it's not as bad now, but when I got out into practice about 15 years ago, the joint injection really carried a bad connotation. And in certain disciplines, it carries
That is true. When I was younger,
really
people
bad.
were like, "Oh, he's got to have his joints injected."
No.
Oh, you don't want that one.
I'm not talking about, like, do we need to take this thing to the hospital? I mean, it was like this major ordeal. And then it was like, all right, we're finally going to have to do it. But really and
They'd
truly,
be like 17 years old before they get their first joint injections, and they're like, "Oh, he's got to have his hocks done." Oh my god.
well, and that was one of the myths, right? When you get into like the things everybody hears, like once you start injecting these joints, you have to keep doing it forever.
I get that is probably the number one question I get. They're like, "Well, does this mean we're always going to have to inject his hocks now?
You're like,
Because you just started injecting his hocks right now?" And I'm like, "Not necessarily."
No.
The answer is not necessarily.
And I think that comes from, I think back, and by the time that we were willing to inject a joint, this joint's trashed, right? It is way past due.
Maybe in that case, yeah. Because
Yeah.
if you wait till they're 17,
Right.
maybe, yeah.
Yeah, I think when I first got out, like that was the thing. Like once you started actually injecting this joint, that joint was so far gone
Yeah.
that we had to do it all the time, because we never broke that cycle. It lived in a chronic inflammatory state. By living in that chronic inflammatory state, our joint was just trash. So we were in these joints constantly.
Yeah.
And what was the real rule? Like, and I hear that a lot. Like, would I need to go ahead and put on the calendar to do this again in 6 months? It's like, no. Like maybe we do it when the horse needs it, not based on the calendar.
Yes.
I think it's good to keep track of.
Yeah.
And I think it's a good idea. Like if you've got an athlete, whether you're feeling anything or not, minimum, I think you need to get them jogged and flexed twice a year. Even if they're perfectly fine and you're not having any issues, I think getting them jogged and flexed twice a year is just your bare minimum. If they need something, we'll take care of it. If not, we're going to be like, hey, everything's great. Let's move on with life, you know?
And some people will have us do that when we go out to vaccinate them twice a year. They'll say at the vaccine appointment, they'll just say, will you jog them and flex them for me just to see what's going on? Or, because we won't inject them at the vaccine appointment, but we can always jog them and flex them and just see what's going on. Or other people will, we could do a totally separate appointment. Or also people will just say, even if it hasn't even been 6 months, but if they're just paying more attention under saddle and they're noticing any sort of changes or resistance under saddle.
Well, and that's one of the things I talk to people a lot about is,
Or on the lunge line. Doesn't even have to necessarily be under saddle.
you know, a lot of times these poor performance issues with joints will kind of creep up on you over time. You don't realize it's an issue. We get these joints medicated. 2 weeks later, like, holy crap, this is amazing.
I got my horse back.
Yeah, and I was like, pay attention to that feeling.
Yeah, they're like, this was the horse that I bought. I was like, yeah.
I tell them,
They're like, that's because that horse was lubed up, ready to go when you bought it.
and, you know, pay attention to that feeling. And when you start to lose that feeling, you know,
Yeah.
then we need to get them back in. We don't, because that's the other thing. You only inject when a joint's lame. Or if a horse is lame, that's when you need to inject. My rule is like, let's don't go that far.
Let's not wait till they're lame.
Yeah, let's don't wait till it's obvious.
Yeah.
Let's get ahead of this, right? Not just inject for no reason, but at the same time, when you start to feel there's an issue, let's take care of that joint. Then again, let's break that cycle. And also, let's don't have those bad days, because bad days can lead to bad habits, right?
Yes.
The number of horses I've had that kind of want to swap on course, and it's because they hurt. Well, now they're starting to develop a habit. And when you start to develop that habit, you got to break that habit. You got to get them comfortable again. You got to break that habit.
Yep.
And so let's just don't develop that bad habit to begin with.
That's right.
The other thing I think about is compensatory lamenesses. How many horses? Because let's say their hind fetlock's a little bit sore, left hind fetlock's a little sore.
Oh my gosh. Then they start going lame in their front end.
Front end starts having an issue because they're offloading.
Yep.
All of a sudden they're bearing more weight on the other side. Let's say left hind's lame,
Yep.
or not lame, but left hind joint sore. They're putting more weight on that right. More weight on that right. That's going to set us up for uneven weight bearing. It may even set us up for some type of a soft tissue injury. And so making sure we keep those horses comfortable, one, keeps us from developing those bad habits. But then also can, in some instances, I do wonder, does it help prevent some of these lamenesses because we're not overloading another structure.
Oh, I 100%. Oh,
So-
yeah. I can't tell you how many lamenesses I've gone to where like the horse is lame on 3 out of 4 legs
Mm-hmm.
because there was one glaringly obvious problem where it all originated, but these other things kind of branched off from it.
Mm-hmm.
Yeah, absolutely.
So I think one of the things we keep saying is like pay attention to your horse. Don't be afraid to do this. So into some other myths that we always hear. My horse is too young to need an injection. We kind of touched on that.
Well, that's false because I just x-rayed a quarter horse the other day that was 2 and the hocks were already fusing.
Yes.
So that's false.
Well, and one of the things I like to think about is, right, you got age of the horse and you got age of the joint.
True.
The analogy I like to use is let's go on down to UGA, right? Let's go down to UGA. Let's go grab the running back and let's go grab the captain of the debate team. All right. We're going to look at their knees. All right. They're both 20 years old.
Yeah.
All right. The running back's 20 years old and the captain of the debate team is 20 years old. Those are not the same knees. They've had way different wear and tear on them. And it's the same thing with your horses, right? So it's not, that's why I always talk about age of the joint. If you've got an athlete, it's got a lot more wear and tear on that joint than just a horse walking out in a pasture, a horse is trail riding.
Yeah.
You know, so these things they matter.
Yep.
So look at the age of the joint, not the age of the horse. They're
You have to
not the
consider
same.
how long and how hard that horse has been working.
Right.
You know, I considering quarter horses and race horses, they go to work when they're babies.
Yep.
I mean, they put them to work, and I'm not talking just a little bit of work. They go to work,
Right.
starting from when they're basically infants. So
And I think that's a huge factor.
it is. It
When
is.
did this horse go to work, and then how much work is he in? So you've got to consider those things. So again, if we're not going to use a calendar to know when to inject, as far as how often to inject, I don't think we can use that same count. We don't want to use that same calendar to determine when should we start injecting. We shouldn't say, well, he's only 7, he's
Yeah.
only 9, he's only 3.
But he's been in work for 6 years already.
Right. And
And hard work.
he's been a high level, he's been a high performing athlete.
Right.
He's going to need it sooner.
Right.
Again, running back, debate team.
Think about it.
Good
Your
deal.
7-year-old quarter horse has already been in hard work for 5 years.
Mm-hmm.
And you think about it, that's the exact same as a 10-year-old warm blood, because most 10-year-old warm bloods have also been in hard work for about 5 years, because most
Yes.
warm bloods don't get started until, like, really they don't get a person on their back until they're 4.
Right.
So think about that.
You
know,
got
it's
to
like-
consider that.
Yeah.
You know, the other thing I hear a lot about is injections just mask pain. All we're doing is masking pain, and that cannot be further from the truth. Again, we talk about the cycle. It's not just about pain control. We're actually breaking that cycle, returning that joint to normal. We'll get into this more when we talk about what we're putting in the joints, but a long-acting steroid on the joint, we're going to get about 30 days at best, right? So 30 days is about how long that steroid will last in the joint if we're using something like a betamethasone.
Right. Steroids, actually. So that's the classic, that's old school, steroids is like the OG, what we use for joint injections. That was the original. And that's still like by far the most common thing that gets injected into joints is steroids, which
Still a great product.
still a great product. Don't get me wrong. But the actual steroid doesn't stay inside that joint capsule for very long, but because it diffuses outside the joint, but the effects of the steroids, as in the decreased inflammation, what he's talking about, that stays around for about 30 days. So
So we'll get those effects where we return that joint to what we call homeostasis. We return it back to
Yeah.
normal function. We've broken that cycle.
Right.
And so you look, 30 days, the steroid had an effect on the joint, but the rest of the time, that's just the joint taking care of itself. And so there's no way, it's not just about that pain control, it's actually about treating the joint. And we'll get into more of that when we're talking about other products, because there's, in the last few years, a lot of products have
it's
come
a
out.
lot of options now. I was
Right.
just looking last night and I was like, wow, because I was making a list and I was like, wow, there's actually like, when I actually go and write them out, I'm like, there's
Well,
a lot.
It was about a year ago, I think we did a whole series on YouTube about all the different products that are out there, where they work and how they work. You can find that on YouTube. We're going to review it again in the podcast, but there was a lot of episodes.
Yeah.
Because we started going through this, and I mean, by the time you touch on the biologics, which there's several biologics.
Yeah.
And then you start getting
But
into
then the hydrogels.
The hydrogels. There's not just one or two of those. There's 2 different hydrogels.
Yeah.
You start getting into steroids and HA.
Yeah.
And like I said, the biologic list,
I just
can
kind of
think
like there's the synthetics.
Yeah.
Well, there's the steroids, the synthetics, and then the biologics. And it's like,
I can think of 5 different biologics just off the top of my head. I mean, it's a lot of things out there, and we're going to break all that down. But
yeah.
So I guess bottom line, it's not just about masking pain. It's about returning that joint to normal function and preventing deterioration of the articular cartilage. Once you lose that cartilage, you're done. You know, I always said if I can figure out how to regrow joint cartilage, I'm done. I'm out. I got my pirate ship. I'm hanging out in the Caribbean, and my grandkids will never have to work. But
Yes.
downside, I don't know how to do that. So
Yeah.
I'm gonna keep doing the job I love every day.
That's right.
You know, we've already touched on this a little bit. One of the questions I get a lot: injections destroy joints. You know, we touched on that when we're talking about the steroid-induced chondromalacia people. Absolutely, people. There's an issue with that.
I think not injecting joints destroys joints because
Well said.
I mean, we've said it 10 times, but all of those pro-inflammatory cytokines are exactly what is destroying your joints. So if we don't get in there and do something, they're just gonna be allowed to run rampant, and you're never gonna get it under control. And then arthritis will be allowed to grow at its own rate.
And the other one I hear a lot about, and especially comes up doing pre-purchases, or people getting ready to sell a horse, or people getting ready to buy a horse. And one of the things always comes up is like, I don't really want to inject him. I'm trying to sell him. I don't want that on the record. You know, because most of the time, if you're selling a horse, you're gonna turn over the records of that horse. And people are always worried, like, well, if they see all these joint injections, they're not going to want to buy them, or the vet's going to have a concern with that. I tell people all the time, I would rather go out, look at a horse, flex it, him flex great, and know he got like his hocks or his coffin joints injected a month or 2 ago, than go out and this horse flex is terrible and somebody said, oh, he just needs these joints done. He may or he may not.
Right.
I'd rather have a sound horse that looks great on that PPE with a history of injections than one that doesn't look great and they're saying you just need to inject him and he'll be
And you're
fine.
like, yeah, I don't know. Maybe. Maybe he won't.
Maybe not. I don't know.
Yeah.
And so I think looking past that, if you're going to sell a horse,
Yeah.
I don't know of a single buyer or a single vet. I'm sure, and I say that, I'm sure somebody's going to make a comment about, oh, I don't want to see that. But the majority of people, vets and buyers included, would rather have a horse that's sound when they get on it, is sound at the time of pre-purchase, flexes good, and had some joints done. Like, I would rather, seeing the history of joint injections on the record just doesn't bother me.
Right. And I can tell you the entire culture around joint injections has changed quite a bit. Like, so since I grew up in the horse world, joint injections we had talked about were frowned upon for a long time. But now that I am a vet and I do joint injections all the time, they're so common to me and so routine. I'm like, oh yeah, he just needs his hocks and coffins, or oh, he just needs his stifles, or oh, there's some fetlocks. Yeah, it's not a problem. And I see how positively it changes that horse's life. And I have no negative connotation towards it anymore. And so to me, it's like you said, I'm like, I would rather know that this horse just needs some maintenance and he's going to be able to do his job. He's going to be great at his job. And I don't know, because that's a really common question I get is, oh, is that a bad thing? What does that mean? Does that mean my horse's career is over because he needs joint injections? I'm like, nope. Actually, it means that your horse is actually probably going to be a little bit better at his career for
exactly.
Once I start doing this for you, he's going to go back to his old glory.
And it makes things easier. A lot of my trainers will talk about that. They're really struggling with the lead change.
Yeah.
We'll go and look at them. We'll get a little maintenance done. These have become so normalized that we call it maintenance. It's like getting the oil changed in your car, getting the filters changed. It's part owning an athlete.
Yeah.
And all of a sudden they're really struggling through this change. Like, I just can't get the change. He's not getting he's not, when it comes to the base of the jump, he's not getting as deep as he used to. My pee off and passage is terrible. And all of a sudden we maintain these horses and everything gets really, really easy again. So it's easier on us. It's easier on the horses. And again, like I said, it's considered maintenance anymore. And I just tell people, like, you got to just plan for that.
Yeah.
Like, when you buy a horse, you're going to have these expenses, right? You got to vaccinate them. You've got to float their teeth. You've got to pay a farrier. Well, just count in those injections. And a lot of times that's the question I get asked when I'm doing the PP is, what am I looking at maintenance-wise on this horse? And it's like, all right, you're probably looking at a once-a-year hocks kind of horse, or we're going to probably work on the hocks and the coffins, or, hey, these fetlocks, they're going to need some attention. And it kind of gives you a plan so you can budget and know where you're at, because these things, if you got an athlete, this is going to happen.
Yes. And another common question I get from a lot of my clients is, how is it why do we have to inject these joints in the first place? Why is it at all? And I kind of, maybe you can explain it a little better. I'm like, it's because it's not that what we ask them to do is necessarily quote unquote unnatural, but we do ask quite a bit of them.
I think that was one thing that the question I get a lot is this something I did wrong?
Yeah, and it's not that you're doing it wrong. No. It's horses can, obviously, they physically are able to do what we're asking them to do, but it's the amount at which we ask them to do it is unnatural. Like, the horses are not made to go out there and do sliding stop after sliding stop after sliding stop, because they do a sliding stop naturally out in the pasture when they're running around and playing, but they don't go in an arena and do 10 in a row, Well,
I think you're absolutely right.
So it's like I think it's the frequency with which we ask them to do things and the intensity with which we ask them to do things, which requires the joint injections.
You were a rider, right? Let's look at the horse and I say this a lot. I go look at the horse that was winning everything 20 years ago. That horse that was winning everything 20 years ago, not going to even be in the B string in the barn anymore.
Yeah.
Like, the what it takes to be successful requires more than ever. And we have, with that same intensity, is going to require more intense maintenance. And it's not that we're doing anything wrong. It's just like, this is what it takes. If you want to perform at this level, this is what it's going to take to do that.
Yeah. I think it's the just intensity and the frequency.
So I think, really to kind of sum this whole episode up, one, joint injections are necessary. You're going to need them. Yep. Don't be afraid of them. Like, don't be afraid. Don't be worried. It's not
a career ending.
No.
It's not a death sentence. I'm not telling you that your horse is broken.
And there's not really a stigma around it anymore. So don't be nervous to inject. If your horse needs it, let's get it done.
Early intervention is critical.
Early intervention. And the other thing is, I think I'm going to say this on every episode, is get a thorough exam, know why you're doing what you're doing, and do what the horse needs. And I cannot say that enough, is that thorough physical exam, thorough soundness evaluation, performance evaluation, whatever you want to call it. Make sure you've got that. So, those are kind of the big points on this. So, thanks everybody for tuning in this week. Like I said, Jenna P., thanks for sending in this question. We're going to be doing very good. It's one of my favorites.
Yeah.
I can't wait. We're going to get some nerd going on. We're going to do a deep dive into.
We'll talk about all the different products.
That you
can put into joints.
I'm pretty excited about this. Not going to lie, I'm pretty fired up. We're going to do that deep dive into the different products and that we can put into joints, when and why. So, again, thanks for tuning in. If y'all keep sending your questions in. If you've got more questions, feel free to reach out to us. You can give us a call, shoot us an email, DM us. I'm getting really good at this. You can DM us, Zoe. Get that DM going.
Fancy.
So, again, thanks for sending these questions and ideas. If y'all got any more, send them in. Love to talk about it. So, thanks. We'll see y'all next week.
Thanks for being here.